So this week we're going to talk a little bit about pericardial diseases, namely pericardial effusions and tamponade, as well as pericarditis and myocarditis. So inflammation of the pericardium, inflammation of the myocardium. We learned a little bit, or we learned already about restrictive cardiomyopathy and how it has some of the similar characteristics to patients who have pericarditis, in that there's impaired ability of the heart to be able to relax during diastole. The differences are, it's a little bit different, whereas with restrictive cardiomyopathy, the issue was within the myocardial layer, whereas with constricted pericarditis, it's an issue with the pericardial layer. So just a little bit of review for our pericardial layers. The pericardium consists again of two layers. So we have the visceral pericardium. So that's the layer that's up against the actual organ itself. So I think about the visceral layers as the inner layer that's against the actual heart itself. So it's continuous with the epicardium. So think of it as a continuum of that epicardial layer. And then we have the second layer, which is the prial layer, the prial pericardium. So that constitutes the thick sac that actually surrounds the heart. So the visceral pericardium is basically the epicardium, the outer layer of the epicardium. And then the prial pericardium is the thick sac that surrounds the two. Surrounds the heart, I'm sorry. So normally we have a small amount of fluid that lies within the pericardial space. So between these two layers of pericardium is the pericardial space. And we have about 5 to 10 milliliters of fluid that normally exists within this pericardial space. And this is to allow for some sort of a certain degree of lubrication, or allow for the proper, when that's the heart's beating and contracting, to allow for a certain amount of free movement of the heart as it's contracting within that pericardial space. So it kind of acts as like a little bit of a lubricant for the heart as it's beating and contracting. The pericardium encloses all four chambers of the heart and actually extends up the great vessels as well. So up the aorta and up the pulmonary artery. So when we talk about pericardial diseases, these diseases can cause effusions to accumulate due to the infectious process that's involved in the pericardium. Most of these processes involve both layers of the pericardium. So this is, that can potentially cause or affect the potentially infect the pericardium and cause issues with patients developing pericardial effusions. So, we can have conditions where it's idiopathic, where they have sudden acute development of pericarditis. The conditions can also lead to chronic idiopathic pericardial effusions. So this could be we can also have infections, either viral or bacterial, which can spread to the pericardium and lead to pericardial effusions. They can be fungal in nature. We can have patients that have certain inflammatory diseases like rheumatoid arthritis and systemic lupus. So these can, again, affect the pericardium and lead to pericardial effusion. We can potentially see pericardial effusion in patients that are post myocardial infarct. So that's going to be our Dressler syndrome. So again, so post infarct, this can be acute after a transmural infarct. We can also potentially see partial or complete free wall rupture. Pericardial effusions can also be due to other systemic diseases that might be underlying in the patient. So examples of that would be patients, who are cirrhotic or dealing with cirrhosis. They have a damaged liver. Cirrhosis, again, causes multi-system issues. So those patients can also wind up with fluid accumulating around the heart as well. So patients with cirrhosis, they'll have typically a fair amount of ascites, so intra-abdominal fluid would be present. These patients with cirrhosis often also have pleural effusions. The effusions can also wind up as around the heart as well in the form of pericardial effusions. Patients with thyroid disease, amyloidosis. We can also see pericardial effusions in patients that have malignancies. So there could be direct tumor involvement that's causing the pericardial effusion, or metastatic disease that could be an issue. Effusions can also be due to lymphatic obstructions. So patients that have malignancies that have infected the lymphatic systems into the lymph nodes. So that'd be, stage 3 and stage 4 cancers. That disruption of the lymphatic drainage system could result in the development of pericardial effusions. Then there's also a list of other miscellaneous situations that could result in patients developing pericardial effusions. So one could be, status post-trauma. So some sort of blunt force trauma to the chest can result in the development of fluid around the heart. Again, as a result of trauma. So that the fluid around the heart, could be blood or bleeding actually into the pericardial space. Any sort of post-surgical fluid collections. So again, patients maybe had some sort of heart surgery. The body's trying to heal itself. As part of that healing process, they may develop fluid around the heart. Could also be post-surgical bleeding. Patient may be undergoing some sort of radiation treatment, possibly for cancer. So that could be radiation induced. Could be a result of patients who have congestive heart failure or even severe pulmonary hypertension. Patients that are in right-sided heart failure tend to develop pericardial effusions. Look on the list. Someone who has Down syndrome actually is more susceptible, as well as pregnancy. So patients who are pregnant, there's always a concern for that. So pericarditis, so that inflammation of the pericardium. So acute pericarditis can be a result of any of those aforementioned etiologies, and may result in variable amounts of accumulated fluid within the pericardium. So the pericardial space is limited in size. Therefore, when there's fluid collection in the pericardium, it can affect the volume within the four chambers of the heart. So this is dependent upon the compliance and the distendability of the pericardium. So how well is that pericardium able to stretch out? How compliant is it? And the degree of which it's distended. Due to this, a large chronic effusion may have little or no effect on the hemodynamics of the heart, while a smaller acute effusion may have a more significant effect on the hemodynamics of the heart. So I'm just going to pause for a moment right there to let you guys kind of just digest and understand that that statement. So basically what that's saying is that when we're looking at pericardial effusions, it's important to just realize that it isn't necessarily the amount or volume of fluid that we're seeing that's going to have a direct impact on the heart itself, on the functioning of the heart. It has to do with the rate at which that fluid is accumulated. So if fluid accumulates very rapidly and very suddenly around the heart, that pericardium hasn't been given the chance to, become compliant and adapt to that sudden increase in fluid. So that pressure is going to build up very suddenly around that heart. So the pericardium is very tight and stiff. It hasn't been able to, kind of stretch out and grow in time with that fluid. So since it's very tight and stiff still, and there isn't much space to work with, a sudden accumulation of fluid is going to put a lot of pressure on the chambers of the heart, and it's going to affect the volumes and the volumes within those chambers. It's going to reduce the volumes of blood within those chambers, and that pressure is going to be translated into the chambers of the heart and affect the hemodynamics within the heart. So we're going to learn in a moment about a condition called cardiac tamponade. So tamponade is a very serious cardiac condition that's considered a clinical emergency that has to be dealt with, rather abruptly because it can or is potentially fatal to the patient. So again, just put that in the back of your mind that it's not necessarily the amount of fluid that dictates its severity, it's the speed at which that fluid accumulates. So acute onset of pericardial effusion is worse than a chronic, long-standing, large volume of fluid. Yes, a large volume of fluid is not good, but if it's been slowly accumulating over time and the heart has gotten a chance to kind of adapt and, the pericardium has become compliant to that amount of fluid, the hemodynamics within that heart may not necessarily be that compromised, even though we see this large, massive effusion. So don't be taken back by, just the degree of effusion. Like if you put your probe down and see a large pericardial effusion, it doesn't necessarily mean that this patient's going to have tamponade. Does everyone understand that? Yes? Shake your
Yes.
virtual heads or give me a virtual thumbs up or a high five or something. Let me know. So it's the rate at which that fluid, good, there you go, Rachel, thumbs up. So it's the rate at which it accumulates, not necessarily the volume. So when we're evaluating the pericardium, we can evaluate it, with our 2D M mode, as well as 3D echo, as well as intracardiac echo. So we have lots of different options. For us, it's mainly going to be 2D and M mode, unless we have a nice fancy 3D probe in our lab. We're going to also evaluate it in multiple views. The absence of a pericardial effusion makes visualization of the pericardium much more difficult. So in the absence of a pericardial effusion, patient with pericarditis, you'll see a thicken or calcifications of the pericardium, but this can potentially be difficult to visualize. So just remember that if that pericardial effusion is absent, visualizing that pericardium can sometimes be difficult unless it's, overtly thickened and calcified, and you can really tell. Pericardial effusions, again, can be detected with 2D, M mode, and 3D. So most often it's going to be our 2D assessment. With M mode, pericardial effusions can be seen as an echo free space located both or either anterior or posterior to the heart. So here we can see, don't look at the 2D picture. That's a horrible 2D picture. But if we're looking at our M mode tracing, so this would be a tracing of our LV. So we could see our posterior wall coming in, coming out. So this is our pericardial layer down here. So we can actually see the pericardial layer looks pretty thickened actually. And during diastole, when the chamber comes in, I'm sorry, during systole, I apologize, during systole, when the chamber contracts, we could see a little bit of fluid present within the layers. So we have our outside layer of the epicardium, the pericardial space, and the thickened layer of the pericardium. This is another picture just again showing the pericardial effusion on the opposite side of that epicardial layer. But again, just remember, this is a single ice pick view. So if you really want to just, get a full assessment, when assessing for pericardial effusion, you do want to utilize multiple views and utilization of 2D echo to get a full appreciation of how much fluid there is, the locations of the fluid. We're also going to be describing, the fluid itself. Does it look simple? Are there any internal septations, any internal echoes? Is it complex in nature? So most echocardiography labs characterize the pericardial effusions as trivial, so just a trace amount of fluid, small, moderate, or large. We further characterize pericardial effusions as either being circumferential, so does the fluid surround the entire heart, or is it loculated? Is it located in just a specific area? So is the fluid just located posterior to the right ventricle? Is it just located around the right atria? Do we see it just located, posterior to the LV? So we're going to use, again, multiple views. So utilize our parasternal long axis, short axis, apical, and subcostal. It's to get a full extent of pericardial effusion. Next, the sonographer must determine if the effusion is of hemodynamic significance. So this is our little breakdown when we're talking about grading the severity of our pericardial effusion. So if we see a small, echo-free space within the posterior to the anterior groove. So if we see a small amount of free fluid in that pericardial space, just a trace amount, we call this just a trivial amount. So if we see a small echo-free space and we acknowledge that there's a small trace pericardial effusion, again, that's just considered trivial. Small is defined as less than 1 centimeter fluid collection seen around the heart. So if we see a collection that's more circumferential, surrounding the heart, but is less than 1 centimeter, that could be considered a small effusion. So this is a diameter measurement that we're doing. So this would be a diameter, measuring the diameter of that fluid in our 2D measurement. And then we can, effusions that are considered moderate measure 1 to 2 centimeters in diameter. And then a large fluid collection would be a diameter measurement of greater than 2 centimeters. So we're going to measure during the cardiac cycle where the fluid collection is the smallest. So if you think about your natural cardiac cycle, when the heart's, systole and then diastole. So if we see fluid, posterior to the right ventricular wall, and we got a good area where we're trying to measure in that area, we're not gonna measure during diastole when the chamber is the largest and that pericardial fluid looks the thinnest. I'm sorry, we're gonna measure during diastole when the chamber, we are gonna measure during diastole when the chamber is largest and that pericardial effusion is the smallest. That's gonna be our true measurement. We're not gonna do it. We're not gonna do it during systole when the chamber is contracted and that pericardial effusion looks bigger. That's not a true measurement because that heart is now contracted. So again, so we're gonna measure when the fluid pocket or fluid dimension looks the smallest during the cardiac cycle. Typically, it's gonna be during diastole. So this is again just showing where a pericardial effusion could be localized or loculated instead of circumferential going around the entire heart. So, if this was our 2D measurement or 2D clip, we would measure just, the diameter. So it would be from from border to border. So inner to inner measurement. You can just, measure across, measure the diameter of that fluid during diastole when the chamber is the largest, or when this fluid pocket looks the smallest. And then we're also going to make sure that, we describe what the fluid looks like. Is it completely anechoic, meaning simple in nature? Or do we see any sort of echogenicity within it, any sort of loculations, stranding, striations, which can indicate that it could potentially be more, instead of actual simple fluid, it could be more blood in nature or pus-like in nature. So that would make aspiration more difficult. So it's a lot effusions that are typically associated with cancers would be more loculated or bloody in nature, and those tend to be more difficult to try and aspirate. So it's also going to be important for us to recognize the difference between pericardial effusion versus pleural effusions. So pericardium reflects around the pulmonary veins, which limits the size of the pericardial effusion behind the left atrium. Pericardial effusions are usually anterior to the descending aorta, and fluid collections posterior to descending aorta tend to be pleural effusions. This is true of the parasternal long axis view. So we're just going to remember, just go back in time. Our parasternal long axis view, our descending thoracic aorta. Just remember that our pericardial effusions are going to be anterior. They're going to, we're going to see, excuse me, the extension of that pericardial effusion anterior. Any fluid collections that appear to run posterior to that descending thoracic aorta are likely pleural effusions. So what do you guys see here? Pericardial or pleural? This is a really crappy 2D picture, but anyone want to take a guess? What do you guys think?
Is it pericardial?
I see a pericardial, yep. And I also see a pleural too. So this is a kind of a crappy picture. So like this little guy here is coronary sinus. Looks like this is probably your descending aorta here. So this looks like pleural. This looks like some lung. And then this is a pericardial here. This one's a little more obvious because they pointed out. So here you can see your descending aorta nicely. You can see a small pericardial effusion and then a larger pleural effusion. What do you guys see in these pictures? Can you guys see these clips?
Yeah.
How would you guys describe this left ventricle? We're going to be sonographers from here on out.
It doesn't look like it's squeezing very well.
Yeah, it doesn't look beaten very well.
And it's like looks really enlarged too.
Rachel, what shape does that ventricle look like? Does it look rounded or does it look like a nice bullet?
Quick question. Is this supposed to be different views of all the same heart, or is it all different ones?
It's all the same heart.
Okay.
So look at this little 4-chamber one down here. Like, does that? Do you remember what we said before? Like, so when the heart's, so she said it's dilated,
Then it's round.
then it's round. Good, exactly. So you hear that? So like anytime you see the left ventricle start looking more rounded as opposed to a nice bullet shape, automatically left ventricular dilatation. That LV is dilated. It's starting to become spherical. So it's starting to become more rounded. That's that sphericity index. So look at the ventricle. Oh, that looks round. So that's got to be a big, I mean, you could tell it's dilated. It's big. All right. What else do we see? So this is now like our short axis view. So now you could see some of that pericardial fluid surrounding the left ventricle. So we know there's fluid around the left ventricle. They went subcostal now. So we can also see now pericardial fluid around the right side of the heart pretty well here. So we have right atria, right ventricle, fluid going around the right ventricle. So we know it's around the left ventricle based on our, short axis view here. See a little bit there. We know it's around the right ventricle. So this would be a circumferential, pericardial effusion. So we're going to learn in a moment about cardiac tamponade. But one of the things that we're going to be looking for when we trying to assess for cardiac tamponade, the main thing is going to be right ventricular diastolic collapse. So that would indicate that the pressures on the outside of the heart are greater than the pressures inside of the heart. And it's so much so that it's actually compressing the chambers and not allowing, the ventricle, particularly the right side of the heart, the right ventricle, to fill with blood. So if we can't get blood to fill into the right ventricle, it's not going to flow to the lungs. So there's not going to be a blood flow going to the lungs. There's not going to be a blood flow then in turn returning from the lungs into the left side of the heart. And there's not going to be any reduced blood flow leaving the left side of the heart. So that's why tamponade, is a critical condition. So you can see how this right ventricle, particularly in some of these, the four chamber and in this subcostal four chamber, the right ventricle looks like it's collapsed down. It's not filling. So if we had our EKG monitor, we can make sure that this is, particularly happening during that diastole period. You can also see some collapse on this side for the right atria as well. So you got some right atrial collapse. But the pressures are much lower in the right atrium. So that's going to be probably the first chamber to, exhibit hemodynamic changes. So you'd be able to see, right atrial collapse prior to any sort of right ventricular collapse. If this becomes severe enough, eventually we'll wind up with, could potentially wind up with left ventricular diastolic collapse as well. In this patient, it's probably unlikely just because this LV is so dilated that these pressures are probably so high in the LV already because of this dilatation that it may not affect it, but so again, with pericardial effusion in disease-free states, the pericardium is rarely visualized with regular echogenicity, with regular echocardiography techniques. If we're doing an intracardiac echocardiogram, we may have the ability to visualize and measure the thickness of the pericardium. In cases pericardial and pleural effusion, the pericardium can easily be seen and measured. In the presence of calcific pericarditis, there's usually shadowing under the pericardium due to the extensive bright echoes of the thick and calcified pericardium. So that could be another clue, that this patient has calcific or calcified pericarditis is the result of this posterior shadowing seen on the opposite side of the heart. So if we get any sort of shadowing artifact, that could be a good indication, that this patient has the presence of calcific pericarditis. In the presence of pericardial effusion, masses, and stranding, the presence of pericardial effusion, masses, and stranding can also be visualized within the fluid collection. And these can occur in either the visceral or parietal pericardium. The detection of stranding or masses are indicative of inflammatory or possible hemorrhagic or even malignant etiologies. Just remember, if that fluid's not simple, appears complex, if there's stranding or any sort of hyperechoic echoes within it, it's more likely hemorrhagic or malignant in nature. All right, so cardiac tamponade. So this is the real, danger that is posed to patients with pericardial effusion. And it's the reason why, we do a full assessment to assess for pericardial effusion in terms of assessing the hemodynamic flow patterns within the heart. When we see any sort of pericardial effusion, we want to, assess the flow patterns through the heart. Is due to rule out, the potential for cardiac tamponade. So when pressures within the pericardial space exceeds that inside the heart, hemodynamic changes will occur. So again, we said it's not necessarily the amount of fluid that can cause cardiac tamponade, it's the rate at which it accumulates. Again, so these are all just, again, etiologies that potentially cause cardiac tamponade. So it's going to be a lot of the same etiologies, that would cause a pericardial effusion. So what's the clinical presentations for patients that have could potentially have cardiac tamponade? Some signs and symptoms would be chest pain, dyspnea, so shortness of breath. Patients will present with tachycardia. So since there's patients with tamponade will have decreased right-sided heart filling, the part will start becoming tachycardic to try, increase the outflow. Since there's less blood flow going in, there's less going out, so the heart's going to start increasing its heart rate. We'll have narrow pulse pressures. So that means that, their pulses are going to, their blood pressures are going to start dropping. This is an important one. These patients present with something called pulsus paradoxus. So pulsus paradoxus is when we see variation in the patient's blood pressures with respiration. So with inspiration, the patient's systemic pressures will drop more than 10 millimeters of mercury than when compared to expiration when they breathe out. So I put a little chart on here in D12. I'm going to pull up in a second to help you kind of understand the hemodynamics a little bit better. For me, I was like, wait, how does that make sense? During inspiration, when we breathe in, good old inspiration and expiration. So we breathe in, diaphragm goes down, right? Pressures are lower in here. We'd expect, more venous return to the heart. So then why does our, blood pressure go down if we have more venous return to the heart during inspiration? There you go. So with inspiration, so this is particularly true when patients have, so there is some normal natural pulsus paradoxes that we all have with patients with cardiac tamponade. It's increasingly exaggerated. So they'll actually have a 10 millimeter drop in pressure, a greater than 10 millimeter drop in pressure between inspiration and expiration. So with inspiration, again, we increase venous return. Right ventricle actually enlarges and then pushes the septum against the left ventricle. So this decreases, again, the amount of filling in the left ventricle and decreases the left ventricular output. So we have lower stroke volume and lower pulse amplitudes. So we can actually see this too as well on our EKG tracings as well. So again, with inspiration now, lungs expand, pulmonary vasculature expands as well. We have increased blood pooling in the lungs with decreased flow returning back to the left ventricle. So we said with inspiration, we have less outflow out of the LV and lower pressures. We can even see it on our EKG tracing too. So with patients with tamponade, with inspiration, we'll see smaller blips on our little EKG tracing. With expiration, we'll see increased spikes on our electrophysiology chart in patients with tamponade. So that's, again, that's our pulsus paradoxus. So we'll also be able to exhibit with patients with tamponade when we're Dopplering our valves and Dopplering our tricuspid and our pulmonic and then our aortic and mitral valves as part of our normal study. We'll also see respiratory variations unmask themselves in patients that are, that have cardiac tamponade. Does everyone understand pulsus paradoxus? Yes. Inspiration.
I'm so sorry. Could you go over that again? I had like a really important phone call that I just got off of.
No worries.
Yeah, oh, but I have to tell y'all real quick, it's hilarious. I had this like hospital ER like bill me incorrectly, and they've been arguing and fighting with me for over a year. And then I caught a HIPAA violation they did, and I was like, y'all performed a HIPAA violation, and now my balance is 0. But anyway, moving on.
There you go. Hospitals are the worst.
Yeah, they like try to play by their own rules, seriously.
Yeah, no, trust me, but just with me with this whole infection thing, like I just went in circles with the nurse and doctor. I'm like, you can give me an antibiotic and in 2 days I will not be infectious. Like I can go back to work. I don't have to worry. But no, that's not our policy. That's not our protocol. We can't do that. Like we can't prescribe antibiotics like that.
Oh, you
Well,
know what happened with that, right? In this state. They were overdosing. I mean, not overdosing, but they were over prescribing antibiotics like
Yeah.
too much. Like they were being like antibiotic happy. Like
Yeah.
I get what you're saying. Like now they're like too scared to do it.
I know.
Like now they're like being like too like
To
not wanting to do
the
it.
extreme the other way. I know.
Yeah, not in the middle.
Not in the middle. I know. I was like, I understand. Yeah, if I have the opportunity to just be at home and I'm not I'm like, you understand my work. Like I'm in hospitals, I'm with students who are then in clinical setting. Like this doesn't make sense. Whatever. It's my own speech. That everyone just needs a primary care physician that they like and trust. That's basically the moral of the story. Find a good primary. Don't ever rely on hospitals and like, urgent cares and all that. So I gotta get a good primary.
Oh, I'm sorry, this is really off topic, but I forgot to ask you in the vascular class. But like with the traumatic brain injuries, like when it does, like you were saying something about like the arteries or something, like they can I forget what it was, like constrictors, like not constrict or something, but like try to do like a defense mechanism in a way to protect you. Is that like just at the moment, or could that like go on? Could
A
it like stay
defense.
that way as you heal? Or like is it only at the moment that it affects your arteries in the brain?
So patients who have traumatic brain injuries, they wind up with increased pressure, which could result in particularly patients that have any sort of brain bleeds, or if they had trauma to the brain and they're bleeding within the brain, they'll remove the portion of the skull to try and relieve some of the pressure. And then they'll have these patients basically on a 24-hour transcranial Doppler to assess for the potential for vasospasm, because those patients have a very high incidence of going into vasospasm. So they'll be doing 24-hour continuous monitoring of transcranial vessels, and they'll try and get ahead and then be able to administer, vasodilating medications to try and keep those vessels from constricting and having the patient go into a vasospasm. So they'll do that during
That's just like when that happens, right? Like that doesn't stay that way. Like it couldn't stay that way. Because my brother the other day fainted for no reason.
Hmm.
And like he had a traumatic brain injury in the past, like a couple years ago. And they tried to tell him that it was electrolyte imbalance. He just like literally passed out. And my brother's like the best with like drinking water and like taking care of himself. So it was really
Well,
hard for me to accept that he had low potassium.
well, if he's just drinking a lot of water, then that actually is a potential, could possibly be true. I mean, because the
Well,
water
like
will dilute.
not like an exaggeration, but like like what you should be doing.
Yeah.
You know what I mean? Like he's, I think, pretty good at taking care of himself.
I mean, it is possible to overhydrate where you could lower your sodium and potassium levels to a point where, you could damage yourself. I mean, that is a possibility. Like, because I used to run and I know, like, marathoners, I'd be like, don't overhydrate, because you could then do more damage than good, by overhydrating, because you can disrupt your sodium and potassium levels. So that's why, like that's why Gatorade came along, that has potassium and sodium in it, to maintain those electrolyte balances, as you're sweating them out, particularly. I mean, that is a possibility. I can ask. I'll ask some of the doctors I know. I'll send a message out to. I just had Dr. Pellerito on Wednesday with our class talking about contrast agents use in ultrasound, which was pretty imaging. They were using contrast agents to like diagnose all kinds of like malignancies and tumors and stuff like that on ultrasound, better than like CT and angio. And it was pretty interesting, like the work he's doing on that. But I mean, he's a big vascular guy, so he might know if something like that vasospasm could potentially exist, well post, any sort of injury like that.
Yeah, because he went to like a urgent care and like that's where I like didn't really like trust them very much. And I
Oh
was like,
yeah,
oh,
no,
I think you
I
should
know.
still
No,
like get checked though, like because it's not normal to just like pass out like that
no,
for
it's
no
not. No.
reason.
Has it happened before?
No, the only other time where he lost consciousness is when he got hit. Like, he was playing baseball and he had a line drive. He was pitching and it flew right back into his head. And
Oh,
that's the
gee.
only other time he's ever passed out like that, like just knocked out. But like, so it's not normal
Did he
for him. So
black out? Does he remember? Like, was it like
no,
full
he
out?
doesn't remember anything.
So it was like a
Like
full
he even
syncopal
lost a little
event.
bit of memory about that. Yeah, like he
I'm
like
in this most
got
recent
up.
time. I'm in this most recent time.
Oh, yeah, no, he did.
Uh,
Yeah. Like he realized that he passed, like he was like losing consciousness and he like got nervous because I think the only other time that happened to him was when he had the brain injury. He got like real scared. And then I guess, I don't know. I just don't think it's potassium.
hmm. How old is he?
He's 25.
Oh, he's young.
Yeah. I'm
Yeah, I
sorry,
mean,
guys. I didn't want to take up your time, but that's my baby, and I really want to make sure he's okay.
no, it's good. I know Dr. Dan tells you. I mean, I would personally follow up with like, his, I guess he obviously had like some sort of neurosurgeon that did his, you know, surgery, like took care of him when he was in the hospital. Um, yeah, I mean, I would do maybe try and find either a neurologist or probably I would neurologist route since, he has that history. I don't know. I mean,
Yeah,
see
I'm gonna
a,
tell him I
did you
talked
see
to
a
you, so maybe
cardiologist?
now he'll like do it. Because he was like brushing me off, and I was like, bro, I don't think that's
I
normal.
mean,
Like,
neurologist or cardiologist, one of those two. I mean, I would go either one of those two routes. I mean, the other thing, is the heart could cause something like that too. Like you said, I mean, if it's I don't know. But, poor guy. All right, so I'll ask about that if something like, vasospasm or anything like that could exist post-op.
thank you. I appreciate that.
Yeah. All right. So going back to patients with presentation for cardiac tamponade. So in addition to those pulsus paradoxus, these patients would also have elevated jugular venous pressures. So we could potentially see, jugular venous distension. Um, and they'll also present with something called Beck's triad. So what Beck's triad is, it's first and foremost, I like to think of first and foremost as quiet heart sounds. So if the clinician or if you are listening to the heart with the stethoscope, rather than your nice loud lub dub sounds, the heart sounds eerily quiet. It's very, very faint heart sounds that you're starting to hear now. I mean, they're still present, but they're kind of muted. We're also going to see decreased systolic blood pressures because we now, there's reduced blood flow filling that right ventricle because it's being collapsed. So very low blood flow is filling that right ventricle. Very blood flow then is going up to the lungs, which is then reduced blood flow going into the left side of the heart. So we have reduced blood flow leaving the heart. So that's going to result in lower pressures. So these patients will have low systemic blood pressures, quiet heart sounds because things are starting to slow down with the heart. It's not beating as strongly. Again, remember our Frank Starling law: the greater the stretch, the greater the force of the contraction. So if things aren't expanding, chambers aren't expanding with blood, we're not going to have very strong contractions, and we're going to have increased venous pressure. So things are going to start backing up into our venous system now. Again, our jugular veins are going to become distended because the pressure, like right now, the ventricle is being collapsed and contracted. Blood flow is not entering. So things are starting to back up, outside of the heart. So that's Beck's triad. So we have increased venous pressure, as evident by, venous jugular distension. We have decreased systemic blood pressure and quiet heart sounds. So Beck's triad. So accumulation, again, hemodynamics of cardiac tamponade. So again, it's the accumulation of pericardial fluid causes pericardial pressures to rise and compromise systemic venous return in the right atrium. This causes the IVC dilate. Ventricular filling is impaired and cardiac output is decreased. So again, it has to do with the rate at which this fluid accumulates, causes pressure to rise within that pericardial space. So that rising in pressure around that heart prevents the chambers from dilating, from filling properly. So that as those chambers aren't able to fill now, we have reduced and decreased cardiac output. So basically things are starting to slow down within the heart. Intracardial pressures, or the intrapericardial pressure, is influenced by both volume of the fluid and the rate at which it accumulates. So there's a dissociation of intrathoracic and intracardiac pressures due to the insulating effect of the effusion. Relative fixed combined. So there's relatively fixed combined cardiac volumes. This is called ventricular interdependence. So these are some echo Doppler findings on patients with pericardial disease. Some anatomical features could be, again, the presence of pericardial effusion, pericardial thickening, echogenicity of the pericardium, cardial stranding, symptoms that we could see with patients with cardiac tamponade. It's going to be diastolic right ventricular collapse. So that's going to be your big one that you're going to be looking for. Right atrial collapse or inversion. Let's be another sign. On Doppler assessment, we're going to see exaggerated respiratory variation on inflow velocities. So that's going to be on our mitral inflow and our tricuspid inflow. We're going to see phasic variation. So respiratory variation on our ventricular outflow and left ventricular outflow tracts. So on our blood flow leaving the heart, when we're Dopplering, we're also going to see respiratory variations. And we're going to see exaggerated respiratory variations in the inferior vena cava flow. Patients who have constrictive pericarditis. Again, we're going to look for that thickened pericardium. We are going to look for an exaggerated septal shift with inspiration. M mode, we can see abnormal septal motion on patients with constrictive pericarditis. On Doppler, we're going to see, again, exaggerated ENA mitral inflow velocities. So with inspiration and expiration, we expect to see, we'll see exaggerated ENA waves. We'll also see tissue Doppler imaging of the annular velocities. We can use that to help diagnose constrictive pericarditis versus restrictive cardiomyopathy. And we'll see blunted diastolic IVC flow patterns with that expiration. Just for cardiac tamponade is a clinical diagnosis, and echocardiography may suggest a hemodynamic abnormality that may be a substrate for tamponade. Echo alone does not make the diagnosis for tamponade, though. So you may hear a term called swinging heart. So this term refers to a heart's motion with a large pericardial effusion. It used to be a sign of cardiac tamponade, but it is simply a marker of a large pericardial effusion. So it used to be when patients saw a large, swinging heart within the pericardial effusion, they would, automatically assume this patient was in tamponade, but that may not necessarily be the case. It's just an indication, there's a large effusion when you see the heart swinging. A large effusion is more likely than a small effusion to have an increased intrapericardial pressures. So what that's saying is a large effusion is more likely to have, increased intrapericardial pressures than just a small one. And then there's also something called electral alternans. So the mechanism seen with the large pericardial effusions, as the position of the heart varies from beat to beat, its position on the EKG also varies. So we could see variations in the EKG tracings because the heart's actually swinging, and the position is swinging, and the position varies from beat to beat. So again, we're going to use our more specific hemodynamic signs for diagnosing cardiac tamponade. So the most important is going to be our diastolic right ventricular collapse and exaggerated right atrial collapse during ventricular diastole, as signs to validate that there's increased intrapericardial pressures. So that right ventricular collapse can be seen during systole and can be documented on M mode as well. So here we could see, so this is our long axis view. We have the M mode going through the right ventricle here, and we are able to see with our cardiac cycle during diastole, right before our QRS. So this would be systole, QRS is here, so systole. Then during diastole, we can see how when the chamber should be filling, it's actually collapsing down towards our intraventricular septum here. So you can also see your M mode tracing here. So this is during diastole. So this is when the mitral valve's open during diastole. We see that wall of the right ventricle collapsing down towards the intraventricular septum. This is actually all fluid too. So this echogenic space above or anterior to that wall of the right ventricle represents fluid. So you can actually see it up here. So this is all fluid now. So large pericardial effusion. So the ventricular alpha tract is likely to be the more compressible area of the right ventricle with significantly elevated intrapericardial pressures. This tends to collapse. When the collapse area moves more into the body of the ventricle, this is indicative of even more elevated intrapericardial pressures. So RV and RVOT collapse can be visualized in the parasternal long axis, short axis, and sometimes in the apical four chamber view. Exaggerated right atrial collapse can also be seen, and this is an indication of impending right atrial, indication of impeded right atrial filling. So if we see right atrial collapse, this is going to be one of the first things that we're going to see, just because those right atrial pressures are lower. This is an indication that we have the right atrium is being filling of that right atrium is being impeded due to those elevated intrapericardial pressures. So this can be seen particularly with the right atria in our subcostal as well as our apical views. So subcostal view is really going to be, it's excellent for assessing for pericardial effusion because we get a good view all the way around the heart. So it's an optimal window for assessing for pericardial effusion. Hey, Rachel, what's this heart doing?
What's it doing?
Yeah. What does it look like it's doing?
Is that
It's
the
waving at
swinging?
you. Yeah, that's a swinging heart. That's waving at you. It's going, hello. Yeah, that's a swinging heart. So you could see this thing just swinging back and forth within a large pericardial effusion. Do you see anything else? Anything else that you notice on here, Rachel? If you look at the chambers now. So I like to kind of go through a checklist. So particularly when I see a fusion, all right, I'm worried about tamponade. So the first place I'm going to look is the right atrium, because I know that's where it's going to affect the first. So do I see anything with the right atrium? Does it look kind of funky?
Yeah, like the
Yeah, it does.
squeezing. I don't know how to describe that.
Yeah,
the
it
right
looks.
word. But it
Yeah,
doesn't
yeah,
look.
no, you're on the right one. Yeah, squeezing. So it's collapsing in. It's being squeezed in because of that increased pressure. Yes, it looks funky. That don't look normal. That's good. So that's the thing. We gotta start being able to look at things. That don't look normal. So the more we see, in these abnormal cases, like, that don't look normal. Yes, you're right. It's being collapsed. So I also now, so I see that. All right. So we have right atrial collapse. That's not a good sign. So then I move to my right ventricle and I see the right ventricle. It looks like it's collapsing in also. It's kind of hard, like this little EKG tracing, to kind of look at both unless I'm stopping and cine looping back, for systole diastole. It's a little hard, but I mean, the ventricle too itself looks like it's kind of collapsing down, particularly over here by the apex. So it looks like I'm getting a little collapse of that right ventricle up here. It's not nice and round like the left ventricle. So it looks like I'm getting some collapse of that, the RV as well. Yes, so at least you can appreciate, this is a swinging heart. You see the large pericardial effusion and the obvious right atrial collapse and some likely right ventricular diastolic collapse as well. Good.
Is the what's going on with the left atrium?
The left atria?
Yeah, is that like something else getting in the way? Because I don't know, it looks weird.
Looks weird. Well, this guy is probably struggling, so he's probably not getting much blood flow coming into this left atria. It says his pulse is 133. Oh, wait, you said the left atria or left ventricle? I'm sorry.
The left atrium.
Um. So yeah, so we may be having some collapse too of the left atria as well. So if you think about it, pressures are also pretty low on the left atria, compared to the left ventricle. So in terms of collapse, it's gonna start, with our RA and then our RV, and then LA would be like one of the next things to collapse, particularly during during systole, when the pressures are low, like as it's starting to fill. But yeah, we're probably getting a little collapse too. It's a little hard to tell here. So it looks like it might be collapsing. It's right there. So the atria typically shouldn't collapse like that. Maybe we'd see it a little bit better, maybe in one of our other views. Let's see what else we got. All right, what about this one, Mary? What do you see? Is there an effusion, yes or no? That's the first thing you have to do.
Yes.
Yes, definitely. So then just kind of go through your chambers now. Start at the right atria. You see anything with the right atria? Does it look funky?
It kind of looks like it's collapsing.
It does, yeah, for sure. Yeah. Look at the left atria. That's kind of what the left atria normally does. Like we never really see the left atria really like contract like a ventricle. Like, I mean, you see small changes in size, but it's really not much because it's always filling. I mean, if you think of our pulmonary vein flow, like remember that pulmonary vein chart? There's always flow coming through forward in that left atrium, both during systole and diastole. It's only when we get that atrial contraction, that little atrial contraction, that we wind up with some reversal flow. And it really doesn't contract significantly that much. I mean, our left atrial size really doesn't, change that much. So there's always filling, during systole and diastole. But when we see it, yeah, kind of bowing in, you see it kind of bowing a little bit. Yeah, for sure. So there's right atrial collapse. It's a little hard to see the right ventricle on this view, but I would for sure say right atrial collapse. So I'd be worried, all right, this patient is either in tamponade or potentially going to be going into tamponade. So from here, then we'll do, our Doppler assessments, and we'll be Dopplering our valves, So we'll use what we get with our Doppler tracings to kind of, match with what we're seeing, with our 2D echo. We looked at this one already. Yeah, we looked at that one already. All right. All right, so in addition with tamponade, so in addition to, our 2D assessments, looking for our right atrial collapse and our right ventricular diastolic collapse, we're also going to assess Doppler flow for our mitral and tricuspid valves, as well as our aortic and pulmonic outflow. So again, there's going to be some degree of variation seen with respiration. With cardiac tamponade, there's an exaggeration So this variation is exaggerated with respiration. And it's going to affect the tricuspid valve first again. So things are going to affect that right side of the heart. The respiration variation is not seen in patients with RV. This is usually due to elevated pulmonary pressures or pulmonary hypertension. So just keep that in mind. So if a patient has right ventricular hypertrophy, we may not necessarily see these respiratory variations just because they have high pulmonary artery pressures to begin with. So this next slide just shows our Doppler tracings, and as it relates to patient to having expiration and inspiration. So it's important to recognize that it's opposite depending on which side of the heart you're looking at. So these top ones show tricuspid and mitral inflow. So we said with when we were talking about pulsus paradoxus, with inspiration, we see a decrease in those pressures. That's because, you know, we have less blood flow leaving the heart at that point, so we have reduced pressure. We can see it on the EKG tracing as well. So with inspiration, we had increased blood flow returning back to the heart. So with the tricuspid, we should see an increase in our tricuspid flow. So our inspiration waveform should be higher compared to our expiration. So we can have the patient, you know, take a deep breath in while we're Dopplering, and we should see, you know, augmentation or an increase on tricuspid flow when compared to having them expire, take a deep breath out. You should see a decrease in that flow. So have them take a deep breath in as we're Dopplering, higher, and deep breath out. So conversely, when we're on the left side of the heart with mitral, when they do inspiration and take a deep breath in, we should have decreased mitral flow, mitral inflow. And when they breathe out, we should have increased mitral inflow. So with patients with cardiac tamponade, we have a large exaggeration between inspiration and expiration. This is one of the signs too that there's compromise or increased pericardial pressures affecting the inflow and the outflow of our mitral and our tricuspid valves. I'm sorry, affecting the inflow of our tricuspid and mitral flow. So it can also be documented with our outflow tracts. So our pulmonic outflow and our LVOT outflow. So same thing on the left side of the heart with inspiration, we have decreased outflow. Expiration, we have increased. And then it's opposite with our pulmonic flow. So let's see, what's the best way we can all remember this? So for the right side of the heart, I inspiration increase. So on the right side of the heart, if we have increased flow going to the heart on the right side during inspiration, we're going to have an increase on those things. But then just go back to that little schematic that I gave you about pulsus paradoxus, that even though we have increased flow on the right side of the heart and increased flow, you know, to right side heart and blood flow going to the lungs, it actually decreases pulmonary output because more of that blood flow is just being accumulated in the lungs as the lungs expand. So we have reduced blood flow during reduced cardiac output on the left side of the heart during inspiration. So it's just showing for mitral E velocity with cardiac tamponade. So echo guidance for pericardiocentesis. So again, our first role is to diagnose the pericardial effusion and any hemodynamic compromise. If pericardiocentesis is being considered, the effusion should be observed from multiple views to determine the distribution of the fluid. So we want to find, the largest pocket. That's going to be easiestly accessible. Some facilities use echo-guided pericardiocentesis to help visualize the tip of the needles, so there's no cardiac damage. So this echogenic area is showing the actual needle tip entering into the fluid. So actually visualize the entire needle coming in. I'm sorry, needle's probably coming from this way. So entering into the pericardial space. Any questions about tamponade or pericardial effusion? So mild would be 1 centimeter or less. Moderate would be 1 to 2 centimeters in diameter. Grade 2 would be considered a large pericardial effusion. Is it circumferential or is it loculated, located, in a single area? And then we worry about several factors. So, we're concerned about the amount of the fluid and how fast that the fluid accumulated. So the rate at which it accumulates, is more indicative of its effect on the heart than the actual total volume of it. So a small effusion that accumulates very fast can be more dangerous than a large effusion that's been there for a long period of time and slowly accumulated. All right, so now we're going to talk about pericardial constriction or constrictive pericarditis. More commonly in today's practice, constrictive pericarditis is the result of infectious or inflammatory processes, such as connective tissue diseases. So that could be, again, our amyloidosis, sarcoidosis, infectious, either bacterial or viral infections. Inflammatory processes like, again, lupus or rheumatoid arthritis. Patients that maybe have undergone any sort of pericardial effusion, any sort of radiation therapy or treatment. So constrictive pericarditis. I'm sorry, I'm just getting like all these flash emails like in front of me. Constrictive pericarditis occurs when there's stiffening of the pericardium, usually thickening of the pericardium that constricts diastolic filling of the heart. So again, this is an issue with the diastolic filling of the heart, similar to restrictive cardiomyopathy. Just remember that the difference with the restrictive cardiomyopathy that affected the myocardium, where this is the pericardial layer. So this pericardium forms a shell around the heart, and there's an elastic constriction in which there is variable transmission of intrathoracic pressures to intracardiac pressures. So this pericardial constrictive pericarditis results in elevated diastolic pressures. The physical findings and pathophysiologies are similar to cardiac tamponade. So echo diagnosis for constrictive pericarditis. There are multiple clinical and anatomic and physiologic observations that must be made in order to diagnose constrictive pericarditis. And there's no specific echo or Doppler findings that are complete indicators of constrictive pericarditis. So although, constrictive pericarditis is defined as thickening of the pericardium, just remember if there's absence of an effusion, this can be difficult to assess with 2D echo. The presence of pericardial or pleural effusions makes this pericardium easier to measure. Normal thickness of a pericardium should be 1 to 2 millimeters. Etiologies, so it may develop in the aftermath of virtually any pericardial injury or inflammation. So we could see a lot of the same clinical presentations as patients who have cardiac tamponade, dyspnea and chest pain, jugular venous distension, pulsus paradoxus. So we may also see, dilatation of, so since we have jugular venous distension, we may also see dilatation of the IVC, which would result in, potential patients that have hepatosplenomegaly. We may also see edema and ascites in patients. So this is a unique heart sound that's associated with constrictive pericarditis. This is something called a pericardial knock. And this is caused by early rapid diastolic filling, followed by a prominent halt to flow. So again, our 2D findings, we're going to look for thickened pericardium. So with constrictive pericarditis, the left ventricles are typically normal in size. Patients have normal ejection fractions because the heart's able to contract, it's just not able to relax. We're also going to have respiratory variations with our ventricular inflow. So that's going to be our mitral inflow. We may also see enlarged atria, but to a milder degree compared to patients that have restrictive cardiomyopathy. We may see some flattening of the LV posterior, the left ventricular posterior wall during diastole. We may see abrupt posterior motion of the ventricular septum during early diastole. So this is called a septal bounce. Then again, dilatation of the IVC and hepatic veins might be present because of those increased, because of the inability of, again, the heart to expand and the increased right atrial and right ventricular pressures. So this is just showing that septal bounce. So respiratory variations and flow velocities. So this is going to be critical for us, particularly when we're trying to differentiate between restrictive pericarditis and restrictive cardiomyopathy. So when we had restrictive cardiomyopathy, we didn't have respiratory variation in terms of our mitral inflow, so our ENA waves. We had the patient's Valsalva to try, and unmask and impair, unmask pseudo-normalization, so that stage 2 diastolic dysfunction. But we didn't have these respiratory variations during inspiration and expiration that we see with restricted pericarditis. So constricted pericarditis versus restrictive cardiomyopathy. Again, with our restrictive CM, we see marked bilateral, marked biatrial enlargement. So 2 enlarged dilated atria. With relatively normal chamber sizes. So the chamber sizes, the atria, they're relatively normal with patients with constricted pericarditis. And then the big one is this lack of respiratory variation with our mitral inflow with restrictive cardiomyopathy. And then we see increased variation in patients with constricted pericarditis. And then we can also utilize tissue Doppler imaging and assessing our mitral annulus to differentiate between restrictive cardiomyopathy versus constricted pericarditis. So with tissue Doppler imaging, there's more rapid early relaxation with constrictive pericarditis versus restriction when diastolic velocities are diminished to below normal. So I'm just gonna focus on this just for a minute. So basically what this is saying is that, we'll have with our tissue Doppler, patients with constricted pericarditis, we could have an increased E wave here just because we have, increased early rapid filling. So we can have increased annular movement during that E period. So just remember with restrictive cardiomyopathy, it's an issue with the myocardium, like we said. So as that restrictive cardiomyopathy gets worse, when we do our tissue Doppler, the myocardium, again, it's not moving well during diastole. So this tissue Doppler represents annulus movement during diastole. So as it's getting worse, that myocardium is not moving, so that annulus isn't going to move as much. So in patients that have restrictive cardiomyopathy, we actually have reduced ENA as the disease gets worse and worse. Whereas with constricted pericarditis, we may actually have increases in this E wave. So we have, here we see an E velocity of 28 centimeters per second. So that's one way we can use tissue Doppler to differentiate between restrictive cardiomyopathy versus restrictive pericarditis. So this is just, the outside, that shell of that heart. Think of constricted pericarditis as, the shell around the heart is it's thickened, it's stiff. So it's not allowing the heart itself to expand very well. So the myocardium is still fine. There's no problem with the myocardium. There's no disease in the myocardium. So it could still contract normal. It could still potentially, expand normal. So there's no issue with the actual myocardium itself. being able to expand and contract. So that mitral annulus that's attached to that myocardium, it still can have, fairly normal motion because there's no disease within the myocardium. So this tissue Doppler, when we're assessing the movement of that mitral annulus up and down, with constricted pericarditis, since we have elevated pressures, left elevated left ventricular and diastolic pressures, we're going to have increased early rapid filling. We're going to have a fast motion of that annulus as that valve opens and we get a sudden surge of blood going in, a large E. We're still going to have, a significant motion of that annulus as it's filling. So this chart just kind of breaks down the differences, between your constrictive pericarditis versus restrictive cardiomyopathy. So again, atrial size for constrictive pericarditis, they could appear normal to mildly dilated. Whereas with restrictive cardiomyopathy, that's the telltale sign, that biatrial enlargement. Pericardium, again, appears thick, bright. Restrictive cardiomyopathy appears normal. Septal motion is abnormal with constrictive pericarditis. So we can see a septal bounce, normal with restrictive cardiomyopathy. Septal position varies with respiration. Our mitral ENA waves. So again, patients that have, severe diastolic dysfunction. So they're both, diseases of diastology. So you're going to see, as it's severe, very big E, little a. So most of your filling is going to come during that early rapid filling. So you should have an E to A ratio, greater than 2 in both cases. Deceleration times, again, you're going to have short deceleration times. So that's similar for both. So where the differences come in is with our tissue Doppler. So our annular velocity, so that movement of that tissue, that mitral annulus during diastole is going to be normal for constrictive pericarditis. And it's reduced in patients that have restrictive cardiomyopathy. Pulmonary hypertension can also be another factor that you can look at. So it's fairly rare with constrictive pericarditis. And because you have very enlarged, left atria and right atria, which are indicative of, elevated pulmonary pressures, it's frequent in patients with restrictive cardiomyopathy. You can also look at regurgitation. So you're frequently going to have MR and TR with restrictive cardiomyopathy, not very common with constrictive pericarditis. But again, the big ones, to be able to differentiate is that respiratory variation. So we see exaggeration between inspiration and expiration on our mitral and tricuspid inflows versus normal. So we don't see any marked respiratory variation on our mitral E velocities. So they remain constant during the patient's inspiration and expiration. So use the respiratory variations and our annular velocities to, really differentiate between restrictive cardiomyopathy and constricted pericarditis. That's basically your real main takeaways. So these next few slides, we kind of really went over already with restrictive cardiomyopathy. Again, we know it's idiopathic secondary to heart muscle disease, creates a stiffness in the myocardium, which causes pressures in the ventricles to rise quickly with small increases in volume. This leads to diastolic heart failure. Again, we know systolic function is typically normal. Wall thickness is usually increased secondary due to infiltrates within the myocardium. But the increase is not as much as with hypertrophic cardiomyopathy. And just kind of recap, remember amyloidosis, our most common cause of restrictive cardiomyopathy in the US. Some other causes, carcinoid syndrome, glycogen storage disease, hemochromatosis, and sarcoidosis. Can also potentially be caused due to malignancy, treatment induced, like from radiation treatment. Treatment is often unsatisfactory with restrictive cardiomyopathy, and prognosis is usually poor in adult population with progressive deterioration. Prognosis is especially poor in children with heart failure. And patients who do not respond to therapy usually die of low output cardiac failures unless cardiac transplantation is an option. Just showing some signs and symptoms of restrictive cardiomyopathy. And complications. So we already knew that thromboembolism, particularly, we worry about left atrial thrombus because that has the potential to embolize and cause stroke. So if we have thrombus in the left atria, those left atria, the atria are large, they're dilated. We wind up with stasis or swirling of blood, that's smoke within the atria, setting the stage for potential thrombus formation. We particularly worry about thrombus formation in the left atrial appendage. And then the risk of that thrombus embolizing. So if it's in the left side of the heart, it'll potentially travel into the left ventricle. And then the left ventricle could potentially, pump it out into our systemic circulation. So from there, it's wherever one feels like going, decides to shoot up one of the carotid arteries and go to the brain, it can. If it decides to, make the turn around the aortic arch and shoot down the body, maybe go into a renal artery, lodge into a renal artery, stop blood flow to one of your kidneys, it can. If it decides to, get into one of your mesenteric arteries, go into your hepatic artery, it could. Go into your SMA, it could. If it wants to travel down into the legs, so be it, so that's the risk of these cardiac emboli. There really is no real rhyme or reason as to, which artery it decides to go into and where it ultimately winds up. Other symptoms of restrictive cardiomyopathy or dysrhythmia. So AFib is the big one. Those atria is large, they're dilated. They're obviously going to wind up with some sort of arrhythmia to them. So AFib being the most common. Patients can wind up with cardiac cirrhosis and progressive deterioration of cardiac function. Again, the myocardium takes a speckled granular appearance, particularly with amyloidosis. Our telltale sign is this marked by atrial enlargement. Small to normal LV cavity size, and there's the possibility of left ventricular hypertrophy due to the infiltrative nature of these diseases infiltrating the myocardium. And there's typically normal, again, systolic function. I'm not going to go over these things again because we kind of went over them. So patients can actually be born without a pericardium. So this is something called a congenitally absent pericardium. So it can either be a partial or complete. So a segment of the heart that does not have a pericardial layer, or it can be the entire heart that is not surrounded by the pericardium. It's more frequent in males. Maybe asymptomatic, or the left atrial appendage. More frequent than the right atrial appendage, can be herniated through the pericardial defect and become strangulated. So one way to diagnose that a patient may have an absent pericardium is they have abnormal or unusual echo windows. So think about it, they don't have that sac that heart is now sitting in. The heart, has the ability now to shift around and move, within the mediastinum, and potentially be sitting in kind of an off position than what we typically, be imaging. So if, you put your probe down and this patient, the views don't look just right, they have kind of abnormal where you normally put your probe, it doesn't seem right. And it may be due to an issue that this patient may not have a pericardium holding the heart in place. So the heart may shift to the right. Abnormal or frequently, there's been reported paradoxal ventricular septal wall motion. Patients may also develop something called pericardial cysts. So these are a benign developmental anomaly that are more commonly found near the right atrium. Pericardial cysts are the most common benign tumor of the pericardium. And just note that they can range in size. So they can be very small as 2 centimeters, to very large. So as big as 16 centimeters. Most commonly seen in the Middle Ages, between 30 and 50 years of age. But they must be differentiated from pericardial effusion. Potentially could be mistaken for a dilated coronary sinus or pseudoaneurysm and a pleural effusion. So this was a picture I found for a really decent size pericardial cyst. So you could see there is a pericardial effusion. If you look at this picture, you could see the LV, and then around the LV, you see some fluid. You can see a little bit of fluid near adjacent to that cyst as well. And then you see this kind of oval structure, rounded structure, with absent intraluminal echoes. So again, the definition of a cyst, is a thin-walled structure that avascular, non-vascular. That's typically simple in nature. So this would be a simple cyst. So if I was, assessing this, I would obviously just put my color Doppler on to make sure there's no flow within this, no vascularity, make sure it's not some sort of bleed of any sort. And then, get your typical measurements, your sagittal, transverse, churn on it, get a third measurement with. Pericardial tumors. So again, primary tumors are rare. So we're going to learn in the coming weeks that the majority of primary cardiac tumors are going to be rare. So if we encounter a tumor in the heart, more likely than not, it's a metastasis. If it is a primary cardiac tumor, there are some that can invade the pericardium. So primary tumors are rare, but something called mesothelioma can invade the pericardium. So this is a cancer that's associated with the lungs. So I don't know if you guys hear those commercials on TV, have you been exposed to asbestos? Do you know anyone who suffered from mesothelioma? Call our law offices, So that's a lung cancer or lung cancer that could potentially involve the pericardium. So just the lungs and their proximity to the heart. So that's something that could potentially involve the pericardium. So other tumors could be lipomas or teratomas. That may be intrapericardial, but these are benign and may have echolucency within the mass. You also worry about pericardial clots. Metastatic involvement of the pericardium occurs more often due to associated carcinoma of the lung, breast, lymphoma, melanoma, leukemia, or other malignancies. So if you remember back when we talked about our pericardial effusions and kind of classifying them and describing them, so if it appears loculated and like there's septations within the fluid, if it looks like it's thick, not very, anechoic without the echoes, if there's intraluminal, if there are echoes within that fluid, it's more likely metastatic or cancerous in nature, involves some sort of hemorrhagic component to it. So that's, associated with these metastatic involvements within the pericardium. So these characteristics, these metastases include echogenic structures without a distinct border located on the pericardial surface. So we can actually see these metastatic lesions or masses on the borders of the pericardium. Metastatic involvement is usually associated with large pericardial effusions with or without signs of tamponade. So if you see a large, ugly pericardial effusion, we might be concerned, there's metastatic involvement going on here. So now we're going to switch gears a little bit and now actually talk about the myocardium. So myocarditis is now an inflammation of the muscle of the heart or the myocardium. A wide range of infections and other problems can lead to myocarditis. It often develops in people who are otherwise healthy. So when you have an infection, the body produces cells to fight the infection. These cells can also produce and release chemicals that can enter the heart and damage the myocardium. The heart can become thick, swollen, and weak. So this was one of the issues that patients were having, particularly young men with the COVID vaccination. They were developing cases of myocarditis. I mean, granted, it was rare, the incidences of these patients developing myocarditis, but that's kind of what was occurring, patients were receiving their COVID vaccinations. And, as, normal response to the body, for that COVID vaccination was to, create the cells needed, to fight the infection. And unfortunately, some of those chemicals that were released, as the body's normal immunologic response, some of those chemicals were attacking some patients and creating cases of myocarditis. So, those patients, they were hospitalized, treated, with medications to reduce the swelling and inflammation. So these are some viral causes that can potentially lead to myocarditis. So Coxsackie B virus, Epstein-Barr, cytomegalo, hepatitis C, herpes virus, HIV, and paravirus. So with myocarditis, just realize that viral causes are going to be the most common. The viral is more common than bacterial. If it is bacterial in nature, the cause for myocarditis, some common causes would be chlamydia, so that's a common STD. Mycoplasma, this is a bacteria that causes lung infections. Streptococcal, that's me. Staphylococcal, so any sort of staph infections. Treptonemia, so that's a cause of syphilis. And Borrelia, so that's the cause of Lyme disease. Borrelia. Other causes, potential causes for myocarditis could be fungal or parasitic in nature. Additional causes could be chemical allergic reaction to medications, such as alcohol or drugs, lead. Patients who have allergic reactions to things like, spider bites, or if they're allergic to bees, snake bites. Chemotherapy and radiation treatments can also potentially cause inflammation of that myocardium. And then again, our autoimmune diseases. So that's why these patients that have these autoimmune diseases, they're really suffering, because it really affects, multi-systems in their body. So patients, with lupus or rheumatoid arthritis, they can also lead to myocarditis. I don't know if I guys ever told you a story about the one woman that I had, come through the ED, and she came up for a lower extremity Doppler study. And, she's had previous DVTs before, and she was suffering from lupus, and she has lupus. So she's got, she knows what goes on with it, and she's in constant pain from the lupus, and has a lot of other underlying health issues, and she receives, pain medications to deal with, like the pain of having lupus. Like, I understand, it's a painful disease, and because it affects all kinds of things. And the doctor in the ER was basically, accusing her of drug seeking. She was there because her leg was swollen and she was worried about DVT, and like she was telling the doctor of all these medications that she's on for pain and this and that, and like was basically insinuating that she was just here for more pain meds. And like, she came up to me and like, she didn't want to talk about it at first, but I could tell she was visibly upset, and like eventually just started crying. It's like, they don't understand. Like, they made me feel like crap down there, screw that doctor. And, I'm just, you guys, if you're ever in a situation like that, the hospital has, patient advocacy, and nurse case managers that can handle situations like that. If a patient ever feels like they're being mistreated by anyone in the hospital and they divulge that to you, you can put a call in and someone will come speak to them privately, and get the information that they need, and it's important to be, an advocate for these patients. She didn't want to talk about it. She didn't want to let me know what was going on. And when she started telling me like, what was going on down there and like how this doctor was making her feel, I'm like, no, this doctor shouldn't be talking to you that way. They shouldn't make you feel that way. You have a legit condition, that causes pain, that causes issues. You have history of DVT. Like I'm looking at your old study. You have had extended clots before, that in and of itself is painful. So like the fact that you're here, you're in pain, you're worried about DVT, like they shouldn't be focused on that. They shouldn't be questioning why you're on so many pain medications, like what's the story? Why are you really here? Why don't you go to your normal typical hospital? She came to our hospital because we're a teaching hospital. She trusts our diagnosis and us to do our job well. So she came, quite a far distance from where she lives. They were questioning, why didn't you go to the hospital near you? Why did you come here? Like thinking that like, we would be giving her pain medications where the other hospital wouldn't, that's basically what they were trying to insinuate, so, stuff like that should never be tolerated. And there are avenues you can go down, as a sonographer, to address these things, within the hospital. So never be afraid to speak up, and defend your patients, even if it's against doctors, so. Anyway, that's my little side. Sorry. Yeah, she just stuck out in my mind when I saw lupus again. So again, some signs and symptoms for myocarditis. So these patients can potentially, one of the first things is we might notice is they have an irregular heartbeat. So this could potentially cause fainting, that irregular heartbeat. They may also have shortness of breath with exercise and shortness of breath when they're lying down flat at night. So if that myocardium is thickened, we have decreased, chamber volumes because that thickened myocardium. So that output's going to be a little bit less. So that might result in some shortness of breath. If the myocarditis, starts becoming severe, they might start complaining of sharp stabbing pain in the chest. Depending, on the cause of the infection or the cause of that swelling, they might show signs of infection like fever, muscle aches, sore throat, headache. Oh, Jesus Christ, that's all me. Painful joints, swelling of the joints, fatigue. So treatment for myocarditis, we have to treat the underlying cause, whether if it's viral or bacterial. We can provide medications to help the heart function better, such as ACE inhibitors or calcium channel blockers or diuretics. We have those patients, that are suffering from myocarditis. One of the most important things is to just have them rest and relax. Allow that we don't want to stress anymore the myocardium. So it's already inflamed, it's already swollen. We want to give that heart muscle a chance to really, calm down, relax. So we're going to have those patients, rest and reduce physical activity for at least 6 months. So it's a long period, that it could potentially take for that myocardium to, really return fully back to normal. So we don't want to do anything. We don't want to be go out there running any marathons, doing any sort of strenuous exercises for a good 6 months after, that myocardial infection. And we also have the patients go on a low salt diet. With myocarditis, patients may be hospitalized if he or she develops a blood clot or a weakened heart. If there's abnormal heart rhythms that are severe, the patient may require a pacemaker or an implantable defibrillator. I remember I actually had a young guy who was probably in his 20s who had a case of myocarditis. I believe his was bacterial in nature. Not 100% sure of, his previous history, but he definitely had myocarditis, and he was pissed because he had like all kinds of abnormal heart rhythms, and they wanted to put in a pacemaker for him. And he's like, I can't believe, like, I'm young and like, my heart's doing all this. Like, I was like, I was fine. And all of a sudden, like, I just, bam, like I couldn't breathe. I just felt wrong. And I don't know if it was, he was an IV drug user and he wound up with like, infection, both endocarditis and myocarditis, really infecting, knocking out his heart. But he was real sick. Complications. So if myocarditis, is left untreated, this can potentially lead to heart failure. In rare cases, can lead to cardiomyopathy or pericarditis. Myocarditis, along with cardiomyopathy, are the leading causes for heart transplants in the US with cardiomyopathy. In very rare instances, myocarditis can lead to sudden death. What did it work? Let's try and do a questions poll. So restrictive pericarditis or constrictive pericarditis. Sorry, constrictive pericarditis. How could we tell the difference? What are the two main things that we could tell the difference between restrictive cardiomyopathy?
With constrictive, it doesn't have a biatrial enlargement than normal. You said
With-
versus restrictive, right?
Yeah, so with constrictive, yeah, it does not have biatrial enlargement. So constrictive pericarditis, you want typically have biatrial enlargement. What about the flow patterns? The mitral inflow. A waves.
Was it an increased E?
So yeah, so we're gonna have respiratory variation. So with our mitral inflow, we expect to see, yeah, there's increase for both actually. So with constrictive pericarditis and with restrictive cardiomyopathy, we're both gonna have a big E. Like if you're in stage 4 diastolic dysfunction, you got big E, little a. So patients who have restrictive cardiomyopathy, they're typically on the later stages of diastolic dysfunction. So we're gonna typically have the restrictive filling patterns. So we'll have, if they have, biatrial enlargement, we know those left atrial pressures are elevated. So we're probably past, impaired relaxation, and we're probably well past pseudo normalization at that point. So we're more into those restrictive filling patterns if we see a, biatrial enlargement. Everyone turn your cameras on. I want to make sure I haven't lost you. I want to make sure you're not like, I want to see, because I don't know if I'm talking Chinese, Greek to you all, like if I'm confusing the hell out of you, like, I don't know. It's good to see you. I need to see faces. I don't know if I'm, here, look, I put a hat on because I'm like a disaster. You should see me on my first call. I'm like, hello. I've had a hat on all day. My hair's gonna fall out. All right. I'm gonna draw. We're gonna draw. We're gonna draw our E and our A waves.
BRB, I need to get my charger.
Get your charger. Go on. So we have our E and our A waves. Right? Let me wait for her to come back. Because I want her to answer actually. I'm gonna be riding Rachel the rest of the semester. Feel free to quiz her too when you get with her. Ask her questions. Because we're a team. We're a band of brothers here. We gotta all get to the end. Is that a real dog? It's a little Westie she's got.
She's real. I got
Is it-
another
what
one
is-
over here too.
She's so cute.
She's my baby,
Yeah.
Chloe. She's been sleeping with me this whole time.
I was
Yeah,
about to
she's cute.
comment on the pillow behind you, and then I was like, wait a minute, that's a real dog over there.
Oh yeah, we got a lot of Westie accessories. My mom has like all these little figurines. Like they're everywhere in the house, okay?
Nice.
But yeah, she's real. She's so cute. She's gonna growl. Hold on, wait. Yeah, she's sweet.
All right, so we have mitral inflow. So we have big E and little a. So with restrictive pericarditis, so when we have infection of the pericardium, we expect to see respiratory variation between inspiration and expiration. So my question is to you guys, which one would be inspiration and which one would be expiration? Could like text me individual what your answer would be. So is the E going to be bigger during inspiration or during expiration? So I was saying when we have restrictive pericarditis, when we Doppler our mitral inflow, I'll let you let's get set up. Get plugged in. Get plugged in, Rachel.
Okay, I'm ready.
You're ready. All right. So we were saying what the ways we could tell the difference between restrictive cardiomyopathy. So what we learned about before, and then constrictive pericarditis is that with constrictive pericarditis, we'll have respiratory variation in our E waves, in our E and A waves. So we're still gonna have big E and little A's because it's a diastolic dysfunction. They have diastolic disease. But as the patient breathes, we're gonna have differences between our peak E's. So as they, exhale and breathe in and breathe out, these E waves are gonna change in size. So I was asking them, can we figure out which one is inspiration and which one's expiration? That's what I want you guys to try and figure out. So if this E is bigger is this patient breathing in or is this patient breathing out? So you can go back and look like, through the PowerPoint, through the notes and try and figure this out. So it's also similar to tamponade as well. So it's going to follow the same pattern as a patient in tamponade. So this is mitral. So is the mitral flow going to be bigger during inspiration or bigger during expiration? Guys can shoot me in the text. This big one, is this inspiration or expiration?
I feel like I want to say inspiration, but because I want to say inspiration, I feel like it's expiration.
If that logic works for you, we're gonna go for it.
Okay, final answer, expiration.
Yep. So when we were saying with when we're talking about tamponade, with the right side of the heart being affected first, when we're kind of looking back at some of those inflow charts that I was showing you, I said A, increase on the right side of the heart, I, inspiration, increase, so tricuspid will increase on the right side of the heart during inspiration, so flow will increase on the right side. Pulmonic, same thing. The I increase on the right side of the heart. It's going to be the opposite for the left side of the heart. So if you kind of just use that as your train of thought with tamponade, when we were talking about tamponade, we have the respiratory variation. That's one thing that we look for, that exaggerated respiratory variation. So on the right side of the heart, inspiration would be an increase. So on the left side of the heart, if this is mitral now, inspiration is going to decrease. So you're right. So that is expiration. I know this is kind of all thinking backwards. I'm probably throwing you in circles. Actually, inspiration, expiration, left side, right side. Like I can see I'm confusing the hell out of you, Rachel.
Yeah, I'm a
They talk-
little
I'm
confused.
Yes.
I'm
You're a little
gonna get there.
confused.
It will come together. I hope so.
So we can just kind of go back to the whole diaphragm thing too. So inspiration, we breathe in, diaphragm goes down. So we have nice low pressure in the lungs, low pressure up here. So blood flow is going to go back to the heart. We have increased venous return to the heart. So if you have increased venous return to the heart, the right side of the heart, tricuspid and pulmonic valve will have increased blood flow. So those velocities are going to be higher. So inspiration is going to be higher on the right side of the heart. Velocity will be higher on the right side of the heart. The opposite is going to happen on the left side of the heart. For me, it took a minute. I'm like, but that doesn't make sense. But why? So that's why I put on D2L kind of like that little schematic for you guys to kind of look at it, to try and look at it and digest it a little bit. But the opposite is going to happen on the left side of the heart. So when we breathe in, we have increased venous return, so more blood flow going to the right side of the heart. But for reasons that that are listed in that chart, we actually have decreased cardiac output. So there's actually less blood flow leaving the heart. So those velocities are going to decrease on the mitral side. So with inspiration, you were right. This one's going to be inspiration and that one's going to be expiration. So when we breathe out, it's going to be the opposite. So when we expire, we actually now have increased cardiac output with expiration. So you were right. So with mitral inflow, this is going to be expiration and this is going to be inspiration. for me, it's for whatever reason, I can just visualize the right side of the heart better, and then I just flip it. And I do the left side of the heart. It's opposite for the left side of the heart. So if I can memorize what's going on with the right side of the heart, then I'll just reverse it for the left side of the heart rather than me trying to, memorize and understand the hemodynamics and what's going on the left side of the heart, why, cardiac output is less when we breathe in and try and figure all that out. I just think of, increased venous return when we breathe in. Like I go back to that whole flow from the arms and flow from the legs thing, that about in vascular. I don't know. Does that kind of help you guys a little bit? Kind of. Yes, Mary? Sorta.
So, okay, you said with like tricuspid and pulmonic, with when you inhale, increased venous return to the heart, and then increased velocities on those two. So the EUA would be bigger when you inhale.
Yeah, so their Doppler tracings would be augmented. Yeah, so they'd be larger, bigger, yes. So with inspiration, it's bigger on the right side of the heart, smaller on the left side of the heart. So I just think I increase right side of the heart, left side of the heart, I has to decrease them. So I, inspiration increase for right heart. I, inspiration. At least that's the easiest way I'm thinking about to memorize it. I, inspiration increase for right side of the heart. Left side of the heart, it's doing the opposite. Left side of the heart's bad. You don't like the left side of the heart. The right side of the heart's the good side. Remember with the valves, they're the ones that are early to work and late to leave. They're the good employees. They're early to open and they're late to close. The valve timing. So same thing. Right side of the heart. And then the other thing we look at too is our tissue Doppler. So we can use tissue Doppler to, tell the difference between constrictive pericarditis and restrictive cardiomyopathy. So our tissue Doppler will have normal annular velocity. So with constrictive pericarditis, it's not the myocardium that's affected, it's the pericardium. It's not myocardium, the annulus can still move up and down just fine, particularly during diastole. So we have normal E prime and A prime waveforms with constrictive pericarditis. But with restrictive cardiomyopathy, that myocardium, is affected, and we have severely reduced movement of that mitral annulus with patients that have restrictive cardiomyopathy. So we have, reduced E prime velocities. So we have, that's the other way we can tell the difference. So you guys think you can recognize an effusion and then recognize someone who could potentially be in tamponade? So tamponade, we want to see right ventricular diastolic collapse. That's the big one. Right atrial collapse, that's going to happen first. So we see right atrial collapse. Oh boy, then we start looking at the right ventricle. Does it look like that right ventricle is collapsing? Okay, I see that. This patient has tamponade for sure. And then we also want to look at our waveforms. And if we see exaggeration between rest with inspiration and expiration, that's another indication that we have increased pressures within that pericardial cavity. So that's so we look at those waveforms. If we see difference between inspiration and expiration of inflow patterns, both first, it's going to show up on the right side of the heart. If we see it in the left side of the heart, that's, this patient has severely elevated intrapericardial pressures if it's enough to affect the left side of the heart velocities. So if I give you waveforms that show, differences in inspiration and expiration, you automatically have to be concerned. All right, this patient, is at risk for tamponade, or has tamponade going on, and that, this patient needs to go for surgery. So I want you to be able to look at, the spectral tracings, see those respiratory variations and be like, all right, this is probably a patient with tamponade or potentially a patient with constricted pericarditis. So if you don't see a large effusion and then you see those respiratory variations, then that patient probably has constricted pericarditis. It's not, cardiac tamponade that's causing this. It's not a big effusion that we have to get out. So it's that effusion that, makes the difference, between tamponade versus someone with, constricted pericarditis. So to alleviate constricted pericarditis, they'll actually go in and remove the pericardium. So to know they want to relieve pressure, on that heart. So they'll actually, remove the pericardium. They'll take it out and then allow the heart to be able to, expand properly. Any questions? All right. I think we're good. I think you guys got a little understanding. It's good to see you smile. I've been cooped up in this place for too long. All right. So hopefully next week we're gonna have lab. I promise. We're gonna go full-fledged into apicals.
So we're gonna do lab on Monday and on Thursday for echo.
Yeah. What time do you guys want to come?
I
And
don't
how long
care.
will it take you to get from clinical? Is anyone down in Dover? I think some of you are. Yeah.
I'm at CDC Limestone, but that's the
Yeah, you're close.
yeah.
Juliana's down in Dover, so it might take her a good 45 minutes to get here at least.
Yeah, I think I'm at CDC Dover too.
You're at CDC Dover. Yeah. She's nice. Miss Pyle, Catherine at CDC Dover, from what I've heard. Oh, actually, I know her. I interviewed her. She's nice. She's really knowledgeable. She scans left-handed though, so get used to that. That'll be our next challenge.
Oh yeah, I did my ABI, but I still have my my other comps that I have to do. So I'm gonna have to like squeeze them in because I have 3 more echo location or like rotations, but I only have 1 week at each of them. So I'm gonna have to get them done.
All right. Get it done. Make it work.
You're going to CDC, right?
Yeah, on Monday I go to CDC. So I was thinking about doing long and short with Robin.
Yeah, I was about to say,
Robin.
link up with her.
Yeah, she's nice. All right. Well, yes, that's it for me. You guys can enjoy the rest of your weekend.
Okay,
See you all Monday.
have a good weekend.
Oh, I was gonna say nothing to do with echo though, guys. See you guys. But like my aunt, I won't hold y'all. I'm sorry, I've already done that enough. But my aunt like seriously just admitted to me that she has lupus, and like everybody's been treating her like she's fine. Like I'm the only one that's like been freaking out about it. Like when you were talking about it, I'm like, that's so true. Like people really don't realize like how serious it is.
No, they don't at all.
It's
Like
crazy.
because they think it's just it flares up and it can attack anywhere and it attacks multi-organ systems, So it's a terrible thing to deal with. These people really are suffering. No, for sure. No, my heart goes out to her.
Yeah. I didn't want to interrupt earlier, but I was like, yeah, I feel him on that because people really don't get it.
No, they don't.
But
Alright.
thanks, Dan.
I'll see you.
Appreciate it. Bye.